Micro-ultrasound is emerging as a high-resolution imaging modality for prostate cancer detection. Recent studies suggest that micro-ultrasound may achieve clinically significant prostate cancer detection rates comparable to multiparametric MRI, while offering advantages in accessibility, workflow integration, and real-time imaging. However, one major challenge remains. Unlike prostate MRI, micro-ultrasound currently lacks broadly established standards for training, interpretation, and quality assurance. As adoption increases, structured education may become essential to ensure reproducible image interpretation and safe clinical implementation. To address this, we developed the Mannheim Micro-Ultrasound Curriculum, a structured 2-day training program focused on standardized image interpretation and clinical decision-making. 20 participants completed the curriculum, and participants had either no prior micro-ultrasound experience or only limited exposure. The course combined didactic teaching, interactive case discussions, and supervised interpretation of 85 curated training cases with biopsy or prostatectomy confirmed reference standards. Training focused on PRI-MUS scoring, peripheral and transitional zone assessment, image optimization, and structured risk evaluation. To assess performance, the study used a fixed histopathology-validated test set of 100 micro-ultrasound examinations. 50 cases contained clinically significant prostate cancer, confirmed by whole mount, radical prostatectomy, and 50 cases were biopsy negative. Each participant evaluated 10 randomized test cases before training and 10 different randomized test cases after training. The entire test dataset was seen once before and once after training, while no case was assessed twice by the same person. For each case, readers assigned binary cancer ratings, subjective risk scores, PRI-MUS scores, and management recommendations including biopsy, MRI, or PSA follow-up. After training, pooled diagnostic accuracy increased from 50.5% to 64.5%. Sensitivity for clinically significant prostate cancer detection increased from 70% to 92%. The area under the ROC curve for the overall subjective risk score improved from 0.53 to 0.70. Clinical management recommendations also became more appropriate after training. Poor quality decisions, defined as follow-up recommendations in patients with clinically significant prostate cancer or unnecessary biopsy recommendations in biopsy-negative patients, decreased from 33% to 17%. At the same time, specificity remained limited, increasing only modestly from 31% to 37%. This suggests that training primarily improved cancer detection sensitivity, while avoiding unnecessary biopsies remained challenging. Interestingly, subjective risk scoring improved more substantially than PRI-MUS performance, suggesting that structured visual interpretation may initially be easier to learn than strict application of formal PRI-MUS criteria. Several limitations should be considered. The study used an enriched test dataset with a high prevalence of clinically significant cancer, and all patients had already been preselected for biopsy. This likely resulted in a higher than normal rate of non-cancerous, suspicious imaging finding. Results may therefore differ in lower prevalence clinical settings. In addition, the study evaluated interpretation of pre-acquired images rather than real-time image acquisition or biopsy performance. Nevertheless, these findings suggest that structured, image-based training may support more standardized early adoption of prostate micro-ultrasound. If you are interested in future micro-ultrasound training courses or research collaborations, please scan the QR code shown on screen. This study received support from a grant from the Dietmar Hopp Foundation. We thank the funders for their support.